So, as you know, Quant L makes a number of lasers. They make an SLT YAG combination, SLT laser, and SLT YAG combination. I am the inventor of SLT, and it's been now around over 20-something years, believe it or not. I think that Dr. Leshkar was the first one to use it in France and maybe in Europe. So I'm happy to hear that. And he's still using it, which is which is good. So I'm going to talk a little bit about how to best use SLT in your practice. You know, we're being bombarded by MIGS procedures, and all these new MIGS procedures, they're all, you know, everybody's great now, and we have something for everybody. But again, I don't want you to forget that SLT is a non-invasive surgical treatment for glaucoma, and that, you know, again, we should be probably using this still before the MIGS procedures. But I think the treatment concept, the philosophy of treating the glaucoma patients is changing, and I think the MIGS is really bringing that forth, that we should be treating again earlier. We should be intervening earlier in the disease. We want to reduce morbidity. We want to reduce the progression of the disease. We want to reduce the need for more aggressive therapy, more aggressive surgical therapy. I mean, the MIGS exist because nobody likes to do trabeculectomies. I mean, trabeculectomies are not a great procedure, so none of us like to do them, despite despite that being maybe our bread and butter. And, you know, also we want to reduce medication burden, and as we all know that there's major issues with compliance when taking medications. So I think, you know, I'd like to convince you to use use SLT earlier, use it as primary therapy even before the prostaglandins. Dr. Leshkar and I were discussing this, do you use it earlier? How do you use it in Europe? In the United States, we do use SLT as primary therapy. The patients are very accepting of it, primarily because those patients do not like to pay for the medications. In Europe, I think there's a sort of a different approach of using medications first. But I think compliance is, of course, one of the major problems, and SLT is a great modality to help the compliance issue. We can use it pre-canal surgery. We can also use it post-MIGS surgery. We use it for reducing IOP fluctuation. We can use it in low-tension glaucoma and even patients with chronic angle closure. I think it's a very safe procedure. It's, again, the beauty of SLT is that it's non-destructive. Unlike argon laser trabeculoplasty or even MLT, those are thermal procedures. They coagulate the trabecular meshwork. Despite what Iridex says about a micropulse laser, it's at a pulse duration which is longer than the thermal relaxation time of the tissue, and it does cause coagulation changes in the tissue. And I think that's very important, especially in patients where you're planning on doing a MIGS procedure, because you do not want to see scarring of the trabecular meshwork. This is going to reduce potentially the efficacy of the MIGS procedure when you're doing canal surgery. So why would you want to be fusing the inner and outer wall of Schlemm's canal if you're going to be planning on doing these procedures? So I think that actually, you know, the older procedures, ALT and MLT, are relatively contraindicated when you're planning on those procedures. So using it as primary therapy. And really using it before starting prostaglandins. I think there is I call the SLT disconnect. If you take in a clinical medical education setting, and I think that ASCRS did a study, audience response study. The question was, what modality would you use to initiate IOP lowering in newly diagnosed open-angle glaucoma? And the most common answer is prostaglandins. You know, most of us would pick up the bottle of prostaglandins. But then you ask the question, what would you do as a doctor? What would you want for yourself? And the answer is SLT. Most physicians would want to have SLT as their primary therapy, not take medications. And the reason, of course, is all these reasons. Because, number one, we're the least compliant individuals. We don't want to take the drops. and we don't want red eyes, and we don't want skin and color changes, and we don't want conjunctival changes. So we don't want any of those things. But it's, we give the medications to our patients. So I think most importantly is that we do try to simplify patients' therapy. Again, just looking at the EMGT study, again, a 25% decrease in the baseline IOP reduced the risk of progression by 50%, and the risk of progression is decreased 10% for each millimeter IOP reduction from baseline when looking at these sort of early glaucoma patients. So I like you to think about SLT as really as an outflow drug. It's like an outflow treatment, and it does actually act much like a prostaglandin. It does affect conventional outflow. Dr. Alvarado, who actually I just found out recently just passed away and did some of the pioneering work in this, showed that basically SLT and the prostaglandins act on Schlemm's canal cells in a similar manner, and that, again, will show that IOP reductions with SLT and prostaglandins are really similar. So if you look at patients who were on a prostaglandin and then had SLT, that their effect was reduced compared to those patients where SLT was used as primary therapy. So again, eyes treated without prostaglandin show statistically greater IOP reduction compared to eyes treated with prostaglandin. So actually, my recommendation is that if you're going to be starting actually a medication, we can discuss this, and consider SLT, that actually, again, I would avoid using a prostaglandin. I would be using a beta blocker or an inflow drug. This way, you have an inflow drug combined with an outflow drug to give you improved IOP reductions. SLT's effectiveness as primary therapy compared to prostaglandins, and these are the sort of seminal studies that were done, the most important being the SLT med study, which is a multi-center clinical trial, looking at SLT as primary therapy versus prostaglandins. And that study showed that the patients were either treated with 360 degrees of SLT compared to prostaglandin, again, at that time I think latanoprost, that there were similar reductions. There were no statistical difference between the SLT treatment and the medical treatment. And actually there was less stepped therapy. In other words, SLT had only 11% steps versus medications 27%. So McGilrath similarly looked at SLT versus latanoprost as primary therapy, and again showing similar IOP reductions in the two groups. And then when you look at 20% IOP reduction versus 30% IOP reduction, again, very similar responses between the two responder rates between the two groups. So it's easy to perform. I think it's an in-office procedure, obviously. It's not like ALT. Precise focusing actually isn't required. Again, it's one spot size. It's a fixed spot size at 400 microns. We use, again, between 50 and 100 spots, mostly 100 spots. But again, there's no scarring of the trabecular meshwork with SLT. This is the laser that we use, the Quant L laser, Optimus Fusion laser. Shown here, it does both SLT and YAG, shown here. And again, it's a very nice laser. It's got great optics, and it's easy to use. Again, what we're treating is the entire pigmented trabecular meshwork with the SLT. Now, I don't know if you've seen this. We've developed this lens. This is actually a lens produced by Ocular Instruments. We developed this over the last several years. It's called an indexing lens. It's really kind of cool. There's and it's great actually for the residents to learn how to do gonioscopy. Oops. There's 5 bars. Each bar is 400 microns, the size of the SLT spot size, and then the space is 500 microns, so you can get 10 spots. And then you click it, it indexes, and shown here if this works. Shown here, so you're treating your 10 spots, basically one adjacent to the other. Then you click it, and then you shows where your last spot was, and you continue on. So it basically helps keep your positioning, because unlike argon laser trabeculoplasty, there's no, of course, no coagulation burn to the meshwork. So nuts and bolts applications, again, we primarily use 360 degrees for primary therapy. 180 degrees can also be effective. You do have to be careful for pigmentary pseudoexfoliation glaucoma, or even highly pigmented TMs. Our energy settings, you basically titrate the energy based on TM pigmentation. You want to see these microcavitation bubbles, but not a lot, just minimal microcavitation bubbles. You don't need a lot of these microcavitation bubbles. So in heavier pigmented trabecular meshworks, we start at maybe 0.5, 0.6 millijoules. Lighter ones, 0.9 millijoules. We usually go up to about 1 to 1.1 millijoules. The endpoint, again, is these microcavitation bubbles. And postoperatively, I do use topical NSAIDs. I use whatever's available for that evening and the following morning and the following evening. There's been a study suggesting that the steroids are efficacious in enhancing the response of the laser. I'm not really sure that I agree with that, because the Alvarado showed that we really do need these macrophages, and we don't want to suppress the inflammatory response too much. So I think there's some sort of fine line there, but I think topical NSAIDs, I think, are more than sufficient to control the postoperative response. IOP reduction percentages after SLT, just looking at all the various studies, again, looking at 20 to 25 millimeters of mercury. That's really most where your, or 20 to 25% reduction is really where most of the studies show. Basically, the strongest predictor of success is still baseline IOP, and that's the most strongly correlated with the degree of IOP reduction. So again, if you're at 50 millimeters of mercury or greater than 36, you're going to get up to a 50% reduction. Most of our patients are in this range of 21 to 25 millimeters of mercury, 20 to 30 millimeters of mercury. You're going to get a 20 to 30% IOP reduction. Is it repeatable? I think the answer is yes. I think the bottom line is, without looking at all, going through the studies, is that patients with a successful SLT the first time have a high probability of successful repeat treatment. There's been several studies shown here. This is repeatability of SLT, 38 eyes. First SLT, minimum of 6 months success, and then second SLT, first and second 590, just showing the degree of IOP reduction in the two lasers, first and second laser. And actually, what was interesting was that in this study, that the second SLT treatment actually had a longer survival than the first SLT treatment. So it does, it can be effective. I do think that part of it is the duration. The longer the duration, longer it lasts, the better the probability of success on the repeat laser. So it's a treatment option for all, variety of glaucomas. We use it, of course, POAG, pseudoexfoliation, pigmentary, and pseudophakic eyes. It actually has a great responder rate in steroid-induced glaucoma, those glaucomas produced by your retina colleagues. I've used it in uveitis as well. That's been stable, failed trabeculectomies, even failed MIGs. We're seeing those now. So aphakia, regressed neovascular, and even in chronic angle closure. Overall, again, a low complication rate. There have been these rare cases of corneal edema, which were not quite clear as to the etiology. But you do have to be very careful with pigmentary glaucoma and use lower energy and fewer spots. So my take-home message is really simplify your glaucoma management. Use SLT as primary therapy. I think if you're going to start them on medicines and considering SLT, that I would actually, again, avoid using the prostaglandin. I actually use the beta blockers or alpha-GAN in those cases and start them, and then you can do the laser at some later point. Again, we want to really improve their compliance. I tell the patient the laser is like a medicine. It's just you don't have to take it. You don't have to take the medicine, and you don't have to pay for it. And there's some suggestion, actually, that SLT response may be even predictive of the MIGS response. Thank you very much.